Now I'm going to talk about the choice of chemoimmunotherapy, FCR versus BR. So just to remind you, FCR is fludarabine, cyclophosphamide, and rituximab, which has been our standard therapy for previously untreated fit patients with CLL under about the age of 70. BR, or bendamustine rituximab, is a relatively newer therapy, which had been studied in a couple of what we call phase 2 trials, smaller single-arm trials, and looked rather promising. For that reason, it was studied in a head-to-head trial against FCR, in fact. This was the CLL 10 study of the German CLL study group, where they took fit patients of any age, actually, as long as they had very good renal function and no major medical comorbidities, and they randomly assigned them to receive FCR versus BR. And they found that FCR was better. FCR was better in terms of the likelihood of inducing complete remission where there's no detectable disease, the likelihood of making patients MRD negative, where even with a very highly sensitive test we can't find any disease, and which is likely the first step toward cure. It was better in terms of the overall likelihood of how long the disease stayed away. There was no difference, however, in overall survival. And in this particular study, there was a bit more toxicity with the BR, which is in part because there were no planned use of supportive care measures like growth factors and antibiotic prophylaxis, which are pretty commonly used with these regimens, and which I would certainly recommend that anyone getting FCR or BR get. And that reduces the toxicity significantly. So FCR beat BR in a head-to-head trial. But in addition, we now have long-term follow-up data from 3 different studies showing that FCR results in possible cure in about half the patients, those who have mutated IGH without high-risk cytogenetics. They have a 60% chance of long-term remission, and at that time, many have no detectable disease, even with highly sensitive tests. There is absolutely no evidence at all that BR has any potential to result in this possible cure. After BR, there's continuous relapse. And so for a person who's eligible for chemoimmunotherapy considering this treatment, FCR is really preferred to BR, especially if they are under 65 and don't have any medical problems. In the trial that directly compared these chemo regimens head-to-head, in the patients over 65, some of the toxicity was worse in the FCR arm compared to BR. And again, that was partly because they didn't use antibiotic prophylaxis or growth factors, which would help. But that being said, it could be reasonable to use BR, particularly in this older patient population, but it has to be recognized that one's giving up on this potential for possible long-term cure with FCR. And so really there's a very fundamental distinction between these two chemotherapy regimens in that context. Now I would note, however, that over a certain age of about 70, use of FCR can potentially be dangerous, especially if a person has reduced renal function or bone marrow that has suffered prior insults. And we can't always tell that ahead of time. So for patients over 70, it's generally not a good idea to consider FCR unless your health is extremely good and laboratory testing indicates very good renal function. There is a small subset for whom it's safe, who meet the criteria of entry for that randomized trial. But otherwise, in general, unfortunately, that regimen probably should not be used in older patients. And other options like BR or like ibrutinib can potentially be considered.